Welcome to the Disability and Philanthropy Forum's 2021 webinar series, brought to you by the President's Council on Disability Inclusion and Philanthropy. My name is Emily Harris, Director of the President's Council, and I use she, her pronouns. As a woman with hearing loss, I'm proud to be part of the disability community. I come to you from the land of the Council of Three Fires, the Odawa, Ojibwe, and Potawatomi nations, now known as the City of Chicago. As part of our commitment to accessibility, our panelists and I will each provide a brief audio description of ourselves. I'm a white woman with dark curly hair, wearing rectangular glasses and a purple jacket over a black turtleneck. Behind me is a screen made of rectangles of blonde wood and white paper. A few housekeeping items for today's webinar. We have live captioning today. There are two ways to access these captions. New slide, please. Use the CC button at the bottom of your screen and choose subtitles or full transcript, which will pop up as a box on your screen within Zoom. Or we are also providing a full transcript through stream text if you prefer to access the captions in a separate window. The link to stream text is now in the chat. We also have American Sign Language interpretation today. Just a note that the interpreters will be switching about 30 minutes into the presentation, so you will see someone new on the camera. Today, only our moderators and panelists will be on camera. You will be muted throughout the event. This event is being recorded and you will receive a link to the recording in the next week or so. Although we will be using the chat to share links with you, it will not be available for you to communicate out. Instead, please use the Q&A button at the bottom of your screen to share your questions anytime during the session, and we will have some time to share them with the panelists at the end of the session. If the Q&A is not accessible to you, please feel free to send your questions to communications@disabilityphilanthropy.org. And please note that even if we run out of time to answer your questions, they will inform the resources we create on the disabilityphilanthropy.org website. Check back early and often. We will be live tweeting today and hope you will join us on social media using the hashtag disabilityphilanthropy. You can also follow along by connecting with us on Twitter @disphilanthropy. We are delighted today to continue our conversations about how disability intersects with social justice. Disability is a natural part of the human experience. According to the CDC, 1 in 4 US adults, 61 million people, have a disability that impacts major life activities. Disabilities can be apparent, but such as a mobility disability that causes someone to use a wheelchair. But many disabilities are non-apparent, including chronic illness and mental health disabilities. Disabilities can be lifelong or acquired. We are the only minority group that anyone can join at any time. The COVID-19 pandemic has laid bare the systemic oppression of people with disabilities, and at the same time is increasing the size of the disability community. Health equity and disability could not be a more timely topic. To moderate our panel, I'm delighted to introduce Judy Belk, CEO of the California Wellness Foundation, one of California's largest public health philanthropies, which maintains a core belief that access to quality healthcare is a human right. Her bio and those of the panelists are linked in the chat. Thank you, Judy.
Thank you so much, Emily. I really appreciate that, a warm introduction, and I'm delighted to be here. I just want to give you a little background of where I am and who I am. I am Judy Belk, President and CEO of the California Wellness Foundation. I bring you greetings from the land of Tongva, city of Los Angeles, and I'm smack dab in the middle of Hollywood. So I bring you greetings. I am an African-American woman with a bright red blouse on. Behind me are roses, thanks to my husband. And behind me is one of my favorite paintings, The Country Doctor, by an artist, Walter Mann. And it's a picture of an African-American country doctor providing care to a young child, and I think her grandmother. So I am really delighted to be with you, and I'm really interested for two reasons. Selfishly, I want to learn with you, and I think you're going to leave the webinar smarter than when you arrived, because we've got two amazing speakers with Andrés and Poorna. And also because this issue is important to me both professionally and personally. As Emily mentioned, I run the California Wellness Foundation. We're a statewide foundation in a state where about 20% of our population have some type of disability. We're also a foundation where health equity is centered to our work. And then finally, like most Americans, I have family members and I have friends in my network who are disabled. And I've seen both their successes and the challenges that they've had in getting the support that they need from the government and from their caregivers. So I'm really, this is an issue that's really important to me. We're gonna try our best to have a conversation. I really wish I was actually in the room with all of you as well as with Andrés and Poorna, but we're gonna make the best we can. And I'm gonna now turn it over to Poorna to introduce herself.
Thank you, Judy. My name is Poorna Kushalnagar, and I am the Special Assistant to the Provost for Research and Engagement at Gallaudet University. I'm also the Director of the Center for Deaf Health Equity. I use she, her pronouns, and I come from the land of the Manahoac. We now call that Fairfax, Virginia. I'm thrilled to be here with you all today. My background is plain and white. I'm wearing white as well. I am a brown woman. I identify as South Asian and deaf. My hair is black, shoulder length, and my shirt goes down to about my wrists. Thank you.
Good morning or good afternoon, depending on where you are. I am Andrés Gallegos. My pronouns are he and his. I also come to you from the land of the Council of Three Fires, the Odawa, Ojibwe, and Padawan nations, now known as the city of Chicago. I am a gray-haired Hispanic male with fair complexion. I'm wearing black squared rimmed glasses, and I have on a white shirt with a maroon bow tie with small polka dots. I'm wearing a medium gray window pane jacket, and I am seated in my power wheelchair in my home office. And I'm pleased to be here with you.
Thank you, Poorna and Andrés. And I also I was so excited about joining in this conversation. I forgot to mention my pronouns, which are she and her. So we are ready to start the conversation. Anyone who knows me knows that I'm a storyteller. I love stories. So I'm gonna start with Andrés to share a personal story. We know your bio, it's impressive, but a personal story that illustrates your maybe personal experience or observation of health equity. So can you start with a story? Do you mind sharing a story, Andrés?
Judy, sure. Thank you for the question. Judy, I sustained my spinal cord injury resulting in quadriplegia 24 years ago. this past November in just a horrific automobile accident. And I thought that after I sustained my injury, because of the extraordinary care that I received during my rehabilitation, which lasted over 5 months at the then Rehabilitation Institute of Chicago, which is now known as the Shirley Ryan Ability Lab, that hospitals and healthcare facilities would be welcoming. I was incredibly naive and learned quickly that the extraordinary care that I received at the Rehabilitation Institute of Chicago was because it was and is one of the country's premier rehabilitation centers for spinal cord and other injuries and conditions. I learned that healthcare facilities that are not accustomed to persons with disabilities are not welcoming. I have a number of examples of my own experiences where I've encountered barriers that, as a result of my experience, Judy, as a disability rights attorney, and in my capacity as a council member of the National Council on Disability and now as its chairman, that I know are pervasive for persons similarly situated and that contribute to health disparities. So first, in looking to get an eye examination about 2 years after my accident, I was denied examinations at each of the 7 leading national eye examination chains that have locations in the city of Chicago. I was told that if I could not independently transfer or bring someone with me to transfer me onto their examination chairs, that I couldn't get an eye examination. In one location, I was offered a manual exam, which I was willing to agree to until the optometrist confided that she had not conducted a manual examination in well over 20 years. Second, I had a similar experience at a number of dental clinics that could not accommodate me because either the examination room was too small or I couldn't independently transfer onto the examination chair. I was able to locate a dentist where I could finally make it into the examination room, but I had to stay in my wheelchair in order to get an examination. At that time, Judy, I had a rigid power wheelchair that did not tilt and did not recline, thus provided that I was willing to stay in my chair for the examination, they were willing to provide it to me. Needless to say, it was incredibly uncomfortable and somewhat of a painful event. And then finally, Judy, let me share that I try to go see my doctor annually for physical examinations, but when I do, I rarely get transferred onto the examination table for the absence of lift and transfer equipment and the absence of height adjustable examination tables. As a result, complete physical exams are provided to me as I remain in my wheelchair. In one instance, a physician covering for my regular primary care physician, after examining my upper body, took a step back and looked at me and said that I assume that everything below the waist is fine, and with that walked out. Sadly, it's a very common experience. Like myself, the overwhelmingly number of people in wheelchairs are examined while we remain in our chairs, even though it may be clinically inappropriate to do so. Those are just some examples. I can go on, but what happens is when that occurs over and over again, there's a natural inclination to not to go where you do not feel welcomed. And so instead of people with disabilities using the healthcare system for disease prevention as intended, we tend to use it for disease management. And that paradigm has to change.
Andrés, thanks for sharing. I found myself, my blood, just boiling, just listening to you. I mean, as an able-bodied person, going to the doctor is not one of my favorite ideas. I get a lot of anxiety just thinking about it. I just don't like it. I mean, I don't like going to the dentist. It makes me nervous. I can't imagine the experience that you have on top of that. And I guess this is where you can help. I mean, I think a lot of folks would say, well, isn't that illegal? Wasn't the American Disability Act, didn't that do away with all of that? Help us kind of understand, because it sounds like what you're saying, what your experience and what you shared happens more than we ever want. And is it, providers not being aware? Do we need more training? Do we need laws? What is it that you think we need in order to ensure that folks do not have to go through that type of experience?
Judy, the reasons are all the above, everything that you mentioned. It's the absence of disability cultural competency training for medical residents and for medical students. They're not exposed to disability culture early on in their training. They receive no training after they graduate and begin their residency and career as doctors. And therefore, if they're not accustomed to seeing us, then they don't know how to treat us. They're afraid of us. They don't understand what disability is and how to accommodate us. There are federal laws, the federal non-discrimination mandates that have been in existence well close to 5 decades for the Rehabilitation Act of 1973 and just over 3 decades for the Americans with Disabilities Act. And today, there are physicians and healthcare systems and hospitals that tell us that they simply aren't aware of what their obligations are. So there's a number of things. Education helps, but we really need people inside of hospitals and healthcare systems that recognize the needs of people with disabilities, understand that not providing service that is equal to those services provided able-bodied persons is discrimination, and that they can do something about that. We need champions inside, Judy.
Thank you. Well, there's a lot for us to unpack there. I want to ask Poorna to join in the conversation. First, Poorna, I'm sure you're sitting there like me, just shaking your head. Does Andrés' story and experiences resonate with you? And can you share a little bit about your own story?
Very much so. Thank you. I feel very angry, frustrated, and I feel very much that I've experienced the same thing. I can share with you 2 years ago, and again, after all the disability rights acts that have been passed, it was a few years ago that I had a health issue that had started in 2015 and gotten worse. It declined to a point where I needed surgery. And I was actually looking forward to the surgery because the surgery was required for me to have a better quality of life and to improve my health. So in 2019, I was very busy working full-time, faculty member at a university, juggling multiple responsibilities. And I happened to forget to request an interpreter for my surgery day. I just didn't even think about it until about 10 minutes before my pre-op appointment was scheduled to begin. So I went and, fortunately Google at that time, they had a beta test of a product that was called Live Transcribe, which is available on Android devices and Android phones. I was one of the beta testers in their pilot program. I was very lucky to have that phone with Live Transcribe with me when I went to the hospital. So I thought to myself, well, I can use that for communication. And I was very confident that the medical team would cooperate. I had wonderful experience with the doctors prior to that. Communication had gone well. They had been accommodating. So I went to the pre-op appointments, took off all of my hearing assistive devices, all of my seeing, my glasses, my jewelry, everything. There was only space for one person to come next to me. And so I told my surgeon, listen, I forgot to request an interpreter, but I have this app on my phone, Live Transcribe. I think we'll be able, it's speech recognition technology, very highly accurate. It'll pick up what you say. I'll be able to read that. I can either speak for myself. If you don't understand, then I can text back. And then in that moment, the surgeon told me, no, you're going to have to use VRI, Poorna. That's system policy. We're going to make you use an interpreter because that's how we, as policy stated, our deaf patients will communicate with the doctors, video remote interpreters. So I said, okay. They brought in a machine. Machine was so big, it's like a monitor, they couldn't get it close to me. So they had to put it at a distance at the end of the table. I didn't have my glasses with me, so I couldn't see it. It was right at the foot of my bed. And so I told the surgeon and the medical team, listen, I can't see the interpreter on the screen. Also, the connection was bad. The interpreter was qualified, but technology was not working such that I could see it. I said, could you take that out? And could we go back to the idea of my app? No. The answer was no, and we will not move forward with surgery until we have a certified interpreter. And that's the moment where I became upset because I mean, this had been a 4-year condition, a health condition that had been deteriorating to the point that was severely impacting me. I was really excited for the surgery. Everything was ready. I had taken time off work. I'm a highly educated person, just like Andreas, and this is what I was experiencing as a professional. And in that day, in that moment, it was a matter of cultural humility. I really felt disrespected as an individual. They wouldn't work with me. They refused to work with me and solve the problem the best way that was for me, that we could move forward with my surgery. Fortunately, I had a really wonderful nurse who showed a lot of compassion. And I don't know what she did, but she clearly went and communicated behind the scenes. I don't know, someone else came to me and they looked into a phone, and it took some time. I think I waited about an hour. And then all of a sudden, everything changed. The surgeon came back. They said they would be able to use the app that I had asked for in the beginning, which was a huge relief. They let me even keep my phone in the surgery. And then in the recovery room, I was able to have my phone with live transcribe, and I kept it with me the rest of the time in the hospital. So I just can imagine, yes, it's a systemic issue. And I'm an educated person with very high degrees who's very aware of my rights. But if cultural humility is not there, imagine what other people with disabilities who are underrepresented, underprivileged, imagine what they would have experienced in that situation. So the systemic issue is one that we need to change, because that's truly what's driving health disparities.
Judy, if I may, the issue that Poorna brings up is critically important. Those things were happening to me, and my physicians knew that I was an attorney, and I was able to advocate for myself. Mm-hmm. Think of the people that can't advocate for themselves or may not know what their legal rights are. But the situation that Poorna describes takes place every single day to the deaf and hard of hearing community. And they constantly have to struggle to basically communicate with their physicians and their healthcare providers. And that it's just tragic what happens on a daily basis to the community.
Yeah, I am hearing, again, I'm trying not to get visibly upset. I so disappointed that you guys have had to go through this, and others have. And I guess it's interesting, Poorna, because I think there's a sense that there's been so many changes around technology, for the deaf and hard of hearing. I mean, and you even had an app that you had with you, and you still had issues. So, Poorna, I'm curious, what is your take on what enhancements or improvements needed, either on a policy issue or training? And I'm then wondering if you can then help us understand, given the fact that we are still, in the midst of an epidemic, and what has that meant for the community that you've been involved in and getting health services?
Thank you for asking that question. To answer your first question, I think two things: what's needed for health disparities and health inequities for people, not just deaf and hard of hearing individuals, but folks with physical disabilities, cognitive disabilities. I think what's needed is two. We need to focus at the policy level. It is so rigid at the moment, where it doesn't allow for flexibility, and it lacks, providers can't ask what the person wants or what their needs are to be able to accommodate them. It's sort of a one service for all. That's what I think, that's where we could change and affect that issue in a positive way. When you consider people with disabilities, we have to include them from different cultural communities as well, because disability affects everyone. So deaf people who identify as Black or Latino, Latina, Asian, they might prefer and feel comfortable to have an interpreter who's from the same cultural background, just as they want to have a provider from the same cultural background. And they should have the right to ask for that type of interpreter. And that's totally lacking right now. You either get you get an interpreter, and you get the interpreter who they are given. And again, like you said, Medical appointments are an uncomfortable experience for everybody. They're even more uncomfortable on a personal level. So you want to mitigate that uncomfortability by having a provider who can understand you. But then if you have an interpreter in the room who doesn't share that same cultural background, then it doesn't matter that the provider is. You want everyone to feel comfortable so that you can share health information to reduce misunderstandings, reduce mistakes, and to increase trust. We want people to continue to see their medical providers to decrease that gap. And then secondly, in medical school and education, they need to include requirements for disabilities and CME, training on cultural humility, cultural competency. It needs to be built into those requirements in the curriculum. It needs to be infused throughout. Now, you mentioned the pandemic and COVID-19 and how that has impacted university. Gallaudet has gotten a grant from the National Institute of Health to host COVID-19 related research. And so what we did was interview 250 approximately deaf and hard of hearing adults in the United States, all who are sign language users. We interviewed them during the pandemic last spring. The time frame, let's see, was about April to May, so 2 months. And we interviewed them about their access to healthcare, telehealth, emergency rooms, were they in the hospital overnight? We wanted to gather those experiences. And then 3 months later, we went back for a second interview, the same individuals to get their experiences again. And I'm happy to say that in 3 months, we saw an improvement in their understanding of COVID-19 symptoms. And I think that that is in a large part due to the increased information. It was more accessible in ASL, thanks to the National Association of the Deaf and other state associations of the deaf and nonprofits who are just doing amazing work at providing access through American Sign Language. And I think that's why we saw an increase. There was a lot of advocates working together, banding together to make sure telehealth platforms were accessible too. So there's progress there. We're not there, but progress has been made. And you know, I have to say, the one negative, masks have had a huge impact on the patient experience of deaf and hard of hearing individuals in any medical setting. And now family members are not allowed to go with them. They have to go by themselves and everyone is masked. I've heard so many stories of how many more barriers there are for deaf and hard of hearing patients. Even people who don't use sign language, they speak only and have a hearing loss. Masks are a huge barrier. So there's a push now for clear masks. Clear masks can improve communication for that population and allow hospital policies to adapt and allow a companion to come with a person who has a disability. Because, you know, Judy, as you were mentioning before, medical experiences are stressful. To be able to bring a companion for support is so important, and it provides better treatment. This would allow better access in the hospitals and emergency rooms. I mean, like I said, progress, but we're getting there.
God, you know, you raised for so many issues that, of course, masks would be an issue. And then the issue of someone who's disabled not being able to have their someone with them. I mean, I just recently went through a surgery and you know, I had to do it alone. And again, I was able-bodied, but my stress level just went up because I had to go through that experience alone. Andrés, can you build on what you're picking up in communities and other parts of the disabled community about how COVID, I suspect, has led bare to inequities that have always been there. That's been our experience. But do you have any specific examples to share about, again, the unique struggles that the disabled community has had during the pandemic?
So, Judy, what we saw early on during the pandemic, that there was an unmasking of the deadly effects of ableism. In many states, there were many states like Alabama, Arizona, Kansas, and others that either created or implemented pre-existing crisis standards of care and rationing policies when there was a belief that there wouldn't be enough critical medical supplies or medical equipment to treat everybody. But these were policies that based triage decisions on normative quality of life judgments and specifically excluded people from treatment or significantly deprioritized us because of mental retardation, whether we required assistance with activities of daily living or simply just having a pre-existing condition that is disability. And that effectively state sanctioned discrimination. And very early during the pandemic, we heard stories from across the country that people with disabilities who had to go to the hospital and were relying on their own ventilators, those ventilators were removed from them upon entering the hospital and given to someone whom physicians believed were more worthy of that equipment. I represent the family of Mr. Michael Hixson. Mr. Hixson was a 47-year-old Black man with multiple complex disabilities who died at a hospital in Austin, Texas in June last year. Physicians refused to treat him for double pneumonia, for sepsis, for urinary tract infection, and suspected COVID because they believed he had a low quality of life. When pressed by his wife as to why they were not going to treat him, one of his physicians, and this conversation was captured in a legally recorded conversation with the wife and a family friend, the physician blatantly told her that treatment would be futile, that no matter what their intervention was, that it would not reverse his low quality of life. Now, Mr. Hixson did not arrive to the hospital seeking a cure for his paralysis, for a cure for his brain injury, or for a cure of loss of sight. The futility was not that the acute conditions that he was seeking treatment for, pneumonia, sepsis, UTI, or COVID, the futility was his underlying disability. And so when pressed further as to why they are treating some people for COVID and not her husband, the physicians further stated that because they can walk and they can talk. Afterwards, the physicians withdrew all life-sustaining treatment, including artificial nutrition and hydration, and they placed Mr. Hixson in hospice within the hospital, changed his code from full code to do not resuscitate, and 6 days later, he died in the hospital. That has been played out throughout the country. And again, it's the worst form of ableism. And we know based on studies that how physicians see us is how they treat us. And these just-
you mentioned a word and I want to be sure because part of this is learning. How do you define ableism? Another ism. Tell me about that. How are you defining that?
So ableism is the discrimination against people with disabilities by people who are able or not disabled. These are people who believe because they are not disabled that they have a right or a superior right over people with disabilities, and that their values and their views are what count. And when it relates to healthcare, it's physicians who are not disabled that believe that they have all the answers and do not take into account or respect the views and the input of the patient who is disabled.
Okay, that is, Poorna, can you build on that a little about, how ableism gets in the way in terms of health equity and services, and I'm curious if we could talk a little bit about is it intentional, is it implicit bias? What's behind ableism in terms of how it plays out in health equity? Poorna? I don't think I heard the interpreter, so I didn't hear you.
Me now?
Yes.
Great, thank you. Yes, I can talk about that in the context of research and funding. Is that okay?
Yes.
Great, thank you. So ableism and how this has a negative impact on people with disabilities, I think is something that comes up a lot in research, especially when it comes to federal funding and private funding. So for example, the review panel typically are people from privileged groups, and they typically bring people who have disabilities who are from privileged communities. So they may likely be white and male and also present as having a disability. And so they have a limited lens when it comes to reviewing research studies. They may think that that research is good, and they may not see things such as the lack of diversity. They may have a difficult time helping generalize the study into practices that could be beneficial for all communities, particularly those with diverse backgrounds. And when they overlook that, the funding for the research gets approved with that overlooked. So therefore, it doesn't have a positive impact with people with disabilities and from diverse backgrounds. And so when we talk about including people with disabilities, they come from often privileged backgrounds, and we don't think of those who with intersectional identities, such as those who identify as LGBTQ, those with intellectual disabilities, those who have racial or ethnic backgrounds and cultural experience. And this is an issue that is perpetuated. So what's good for one group isn't good for others. And so it puts a marginalized community at further disparity. And so this is where ableism starts, is actually with the review panel, the scientists, when we're funding research. And I feel that we need to promote diversity way back at the beginning and increase diverse perspectives and promote equitable types of research. And so in order for that to happen, we have to be funding it and reviewing it with those lenses in mind.
Thank you, Poorna. That was really helpful. And you touched on something that I want to probe a little, and that's the intersectionality, because, you know, as funders, foundations, of which I'm a proud member of the philanthropic community, but sometimes we look at funding in boxes. Okay, the here, here, here. What I'm picking up and what I've learned from both of you is one, you know, there are disabled community members throughout the community, and there are issues about race, gender, sexual orientation, poverty, all of those we have to look at. And I was thinking a lot this week about violence. As you know, Cal Wellness, one of our major areas is violence prevention, specifically around gun violence. And I think as the world has focused on what's happened in Minneapolis with the George Arnold trial, and then the shooting of another young Black man, Dante Wright. And as I've continued to read and learn about the unique needs of the disabled community, was stunned about the disproportionate amount of violence against the disabled community. Andres, can you talk a little bit about this issue? And we view, you know, violence as a public health issue. Andres, can you talk a little bit about that?
So, Judy, what concerns me is the interaction between the police and the disability community with respect to the deaf community. Because the police may encounter a deaf person on the street or in their home, not aware that they are deaf, they often misinterpret the inability to follow commands as being resistant or being a threat to them. And the same thing with persons with mental illness, that not understanding that someone may have a mental illness or is having a mental health crisis at the moment can lead to violence, can lead to arrest as well. When someone is experiencing a mental health crisis, the first encounter of any professional will be likely police, not mental health providers, not social workers, not medically trained personnel, but police who have no training in dealing with mental health. And again, what happens is violence is often the wrongful killing of persons who are experiencing a mental health crisis because they're not able to get the medical attention that they need, and because their first encounter is with law enforcement.
Okay, thank you. I just got the word that we have 5 minutes until we open it up for questions. So please, if you have questions, put them in the chat. I'm going to try to sneak in about two more questions. One, I want to just move over a little focus on the philanthropic, community. First, can either one of you share any examples where you feel that philanthropy got it in terms of their funding, in terms of philanthropy using their voice? And then finally, before I turn it over to other colleagues on the call, want you to share one or two pieces of advice that funders on this call can start thinking about, or tomorrow, in terms of how they can be more thoughtful and strategic in supporting the needs of the disabled community. Either Poorna or Andrés, either one of you can start. Why don't we start with you, Poorna? Is that okay?
Sure, I'd be happy to start. So for the funders in the audience, something for them to consider. On their application, when they are starting to choose reviewers to review the applications, make sure that they're choosing reviewers who identify as disabled, and not to stop at disability itself, but also choose folks who have multiple identities, right? Intersectional identities. That way you get many different perspectives reviewing applications. I'd also like the reviewers to look at the research team and the study and the research leadership team to check to make sure that that team includes individuals with disabilities too, particularly if you're doing a study on the disabled community, right? Not putting them in a supporting role, but rather putting them in a lead role. And I also encourage community partnership in that respect. We also want to make sure that disabled individuals who are scientists are being included as well. That way they can help design a well-designed study that has high levels of reliability and ends up with a positive, reliable result that is applicable to the community. And so those are the things that I would suggest, is to include disabled individuals at all levels, including the research and the funding aspects.
Poorna, that's a good reminder, because as I think about who's making these decisions, both in foundations, also on program staff and in the boardrooms, I think foundations probably have a abysmal record in terms of even recruiting members of the disabled community as program officers and on boards of foundations, all which really impact funding and funding decisions. Andrés, what advice do you have for funders, and you have any good examples of any that are doing it right?
So let me quickly just mention a good example of doing it right. The Ford Foundation funded a project for Access Living in Metropolitan Chicago, which is a Center for Independent Living, which I'm proudly have been a board member of for the past 11 years. And it was for a project of the intersection of race and racial justice and disability. So that's one example of doing it right. My advice is that every grant proposal should be scored for disability inclusion. Specifically, how many persons with disabilities are employed by the organization seeking funding, and are we represented throughout the hierarchy of the organization? Are persons with disabilities on the board of those organizations? And are persons with disabilities included in a proposed project? And what effect will the project have upon persons with disabilities? And look, Judy, imagine what could be achieved if each foundation would dedicate a percentage of their funding towards projects that can address the underpinnings of health disparities between persons with disabilities and their non-disabled counterparts. And if they did so in concert, right? If we look at affordable and accessible housing in each city, community-based healthcare centers for grocery stores that have access to nutrition and fresh food, and then projects that can promote the employment of people with disabilities. Funders have the capacity to change society and drive change, and just a tremendous opportunity to do something good for the disability community that Emily said is 25%, nearly 25% of the entire population and still growing.
Thank you. You guys, I could keep asking questions, but I'm gonna not be greedy. I'm gonna share your wisdom with other colleagues on the phone. So I'm gonna turn it over to Emily, who's gonna manage this portion, and then I'll come back and ask one final question.
And you're welcome to stay on, Judy, because some of these questions may be for you as well. Please, we probably have time for a couple more questions. A lot of what's been blowing up in the Q&A section are recommendations from some of our participants on links, as well as blogs that have been posted. We have a podcast. So please rest assured that we will both send those out after the webinar, and also, to the extent possible, include some of them on our resource page on disabilityphilanthropy.org. I want to ask a first question about telemedicine. This panelist mentions that one potential positive outcome on healthcare delivery during the pandemic is increased access to telemedicine, and goes on to say that their child who has developmental disabilities has found this incredibly helpful, reducing anxiety and stress associated with visiting a doctor's office. Can the panel talk about their thoughts on opportunities to ensure that telemedicine becomes part of reimbursable routine care?
So let me, if I can take the first stab at this. So telemedicine has the potential to be incredibly effective. What I'm concerned about is that becomes the go-to substitute for in-person visits, right? So persons with mobility disabilities cannot get weighed in physicians' offices. And if you're an adolescent who uses a wheelchair, many of the medications that are prescribed to you, the accurate dosage is based upon accurate weight and height measurement. And if you can't do that at home when medication is being prescribed to you, it puts your safety and health at risk. At the same time, a lot of the telemedicine platforms are not accessible for the deaf or hard of hearing because they don't accommodate a sign language interpreter on screen at the same time with the physician as well. So there's concern there, although there's potential, there's concern going forward that it be made accessible.
Andres, a related question for you. I think Judy kind of asked this and you touched on it, but somebody asks, isn't it required under the ADA that exam tables be accessible?
So that's an interesting question. The ADA and the Rehabilitation Act require that providers provide us, people with disabilities, with an equal opportunity to benefit from their services. The ADA was written to address the built environment. So with respect to providing services, yes, there's the overarching obligation, but there's not specific language. In the absence of specific language, I see healthcare providers hiding behind that to not provide it, right? So we're working on that. There were regulations that are going to be specifically adopted by Department of Justice to mandate accessible medical diagnostic equipment, but that hasn't happened yet, and we're working to make sure that happens soon.
Andrés, you just said something really important, which just the bulb went off. You said that the ADA addressed the built environment, not the delivery of services and disability rights. That's huge. I didn't realize that.
So it doesn't do that specifically, right? It says that providers, healthcare providers, have an obligation to provide their services or goods or facilities in a manner that allows us to have an equal opportunity to benefit from that, right? But as to services, how they're performed, how they're delivered, there's not specificity in the regulations that I think are missing that need to be provided.
Thank you. A next question for Poorna maybe is, can you provide some information on the different approaches to sustainable deaf, child, and adult community education designed to avoid future real-world conflict issues outlined today?
Certainly. Could you repeat the question, Emily?
The question is asking for information on the different approaches to sustainable deaf, child, and adult community education and how those approaches might help to overcome some of the inequities we've been talking about today.
I'm not familiar with any specific program that does provide the sustainability aspect of this, but there are a lot of resources that are available nationwide that you would be able to check. The State Commission for Deaf and Hard of Hearing, for example. There are best practices that they provide. There are resources also for teaching deaf and hard of hearing children. You could also look at the National Association for the Deaf and the resources that they've collected there. It's hard to answer that question with just one simple statement. I think to find information, you can find information about deaf and hard of hearing children in general, but to find information about deaf and hard of hearing children who have multiple disabilities such as blindness or other types of disabilities, there are not enough resources for. And so I would also say that there should be resources for program evaluation to make sure that you are getting the program impact and sustainability and the results that you are hoping for so that it will contribute to the well-being of deaf children. We don't have enough effective or efficient or effectiveness studies for these programs. And so this is a huge gap that we do need to address.
Great. And then for either of you, we have a question about the high cost of prescription medications, lack of prescription coverage, and high out-of-pocket costs. What can we do to address this on a policy level as well as on the individual level?
Let me address that for a second. One of the things that we're concerned about the National Council on Disability is the overuse and reliance of quality adjusted life years to determine who benefits from life sustaining treatments and new therapies come out. There's actually an equation that's used to determine that if you're a person with disability, and depending on the extent of that disability, it may not be available to you. And how that relates to pricing is that not only are pharmaceuticals and therapies that are developed in the United States relying upon that method, but also foreign manufacturers are as well. And the Department of Justice and Health and Human Services has come out to say it's discriminatory in its use, but yet we still allow some federal agencies to use that. And we know that a number of foreign countries use it when they price their drug price as well. At the National Council on Disability, we're looking to address the pricing of these drugs because it does have a detrimental effect upon the disabled community, but that's one part of it as well. Also making sure that is non-discriminatory.
Judy, many of the other questions are thanks, so I'm going to pass it back to you for your final one.
Sure. First of all, Poorna and Andres, thank you so much. I've learned a lot, and I wish we had another hour or so. Thank you so much for all your work in advancing wellness. In addition to liking stories, I'm a half glass full person. So I'm wondering if you might end with a closing comment about what gives you hope as you think about your work, the communities that you serve, where we are at this point in this country. What gives you hope? I'm going to start with you, Poorna.
Certainly. The pandemic has brought people together. It has brought different communities together to fight for accessibility, to ensure that every person has accessibility to vaccines. And that's what makes me happy and hopeful for this country. Now, with the new leadership team as well being in place, I now feel that there is attention to people with disabilities to ensure accessibility increases going forward. And thank you for including me on this panel, for example, to allow us to share our stories and have an impact message to those people who have disabilities, and not just within society, but within research and with philanthropic endeavors as well. And bringing everybody together to work together to arrive at health equity gives me hope.
Thank you so much, Poorna. I appreciate that. Andres, your thoughts? Hope? Are you hopeful?
Judy, at the moment I am, because of leadership, as Poorna mentioned. Leadership makes a difference, and so I believe that we now have the right federal partners to truly make a difference in the lives of people with disabilities throughout the country. Leadership in organizations such as this that are focusing on equity issues affecting people with disabilities, leadership in the many disability rights and disability advocacy organizations throughout the country that I've had the pleasure of speaking with since assuming my position as the chairman of the National Council on Disabilities. So these are organizations that work tirelessly without much fanfare to address the needs of people with disabilities. And these are organizations that benefit from funding from members of this audience. And so the more support that you provide them, the more hopeful I'm going to be, and the more hopeful the disability is going to be as well.
Well, thank you. Well, what gives me hope is really that we have the benefit of your leadership and your wisdom. What also gives me hope is those who took time out of their schedule to join us. You didn't have to. I know there's a lot of webinars and other programs. And finally, what gives me hope are all of the amazing folks who work so hard in putting together today's program, starting with Emily and her staff. And so, Emily, I'm going to turn it back over to you with our thanks and our appreciation. And I think you have a few final words.
I do. Thank you so much, Judy, Poorna, and Andres, and everything you have said today gives me hope. I've learned so much, and you've given us great food for thought. Following the close of this session, you will receive a short survey. Please help us learn from your experience by taking a few minutes to fill it out. And again, all of those comments in the chat, our team will be taking careful look at and making sure that we use that to inform the disabilityphilanthropy.org website. Please join us on June 10th when New York Women's Foundation President Ana Oliveira will moderate a conversation about gender, sexuality, and disability. And again on September 23rd when MacArthur Foundation CEO John Palfrey will moderate a webinar on climate change and disability. We look forward to continuing to learn together. So to continue your learning journey, please sign up to be a member of the Disability Philanthropy Forum if you work in philanthropy, and if not, just generally to receive our newsletters. Come back early and often to explore the videos and curated resources that address the journey to disability inclusion, and connect with us on social media. And finally, if you're a grant maker and today's discussion has convinced you of how essential disability inclusion is to fulfilling your mission, please encourage your grant-making organization to sign on to the President's Council New Disability Inclusion Pledge. You can learn more at the Disability Philanthropy Forum, disabilityphilanthropy.org. Thank you, and please fill out our survey before you leave.